Good afternoon and welcome. My name is Steve Eck with Modern Healthcare, and I'll be introducing today's Modern Healthcare custom webinar, Orthopedic Market Transformation Through Value-Based Care and Physician Alignment. Thank you for joining us this afternoon. We have a great program and very dynamic expert speakers for you today, so we appreciate you taking the time out of your busy schedules to join us. Stakeholders in healthcare are experiencing downward pressure on reimbursement and growing malalignment between payers, hospitals, vendors, and providers. In today's webinar, you will hear from speakers who have spent over a decade proving a sustainable model in musculoskeletal care that is designed to align stakeholders, move market share, improve profitability, drive quality patient outcomes, and lead the transition to value-based care in sustainable ways. This model has proven to meaningfully bend the cost curve, improve contribution margin for facilities, and improve patient outcomes. It has been replicated repeatedly around the country in partnership with several prominent health systems. Today's discussion will highlight how to create alignment and buy-in among stakeholders to create a transformational service line that benefits patients, hospitals, providers, and payers. Furthermore, strategies to implement standardization and accountability among physicians will be discussed. Before we get started, I'd like to thank our sponsor, Healthcare Outcomes Performance Company, or HOPCo. For the last 10 years, HOPCo has delivered superior and consistent results by focusing on transforming the patient care experience and improving the practice of medicine. They are experts in orthopedic and musculoskeletal medicine and are uniquely positioned to manage health system service lines and integrate physician practices across the country to enhance the healthcare experience for patients. HOPCo has developed an integrated suite of proprietary IT platforms, a robust and deployable infrastructure, and standardized clinical protocols that have proven to help their partners meet the triple aim of reducing cost, improving outcomes, and enhancing patient satisfaction. By managing the entire continuum of care, from initial evaluation through surgery and recovery, they are experts in managing the risk on spend to ensure patients receive the right evidence-based care at the right time and in the right setting. Their proven outcomes have led to unrivaled efficiencies and savings for their strategic partners, and they will be sharing these with you today. A couple quick housekeeping notes before we get started. We want this webinar to be as interactive an experience for you, our audience. You are encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as we have time for. Should you need any assistance during the webinar, please don't hesitate to contact us via the questions pane in your attendee panel, and we will do our best to assist you. I'm thrilled to introduce our speakers for today's webinar, Dr. David Jacofsky, Chairman and CEO of Healthcare Outcomes Performance Company, or HOPCo, and Dr. Wael Barsoum, President and Chief Transformation Officer at HOPCo. Now it's my pleasure to turn it over to our speakers. David and Will, the floor is yours.
Steve, thank you very much for that kind introduction. On behalf of David and myself, we're very excited to share this webinar with you. David Jacofsky, the founder, chairman, and CEO, is a orthopedic surgeon. He is Mayo Clinic Hopkins trained and started HOPCo about 15 years ago, right around the same time he started the Core Institute in Phoenix, Arizona. My name is Wael Barsoum. I'm also an orthopedic surgeon. I trained at the Cleveland Clinic and New England Baptist Hospital. Recently stepped down as the CEO and president of Cleveland Clinic, Florida, to take on this role with my good friend David Jacofsky, and very excited again to share what we're doing in terms of orthopedic market transformation. With that, just to give you a little background on where we are as a country. One of the challenges we have is the fact that we live in a country with truly unsustainable healthcare costs. And I think many of us would agree that this is the best country in the world, but sadly, when you look at our overall healthcare rating, when it looks at quality, access, efficiency, equity, and healthy living, we actually end up ranking dead last compared to all of the wealthiest countries in the world. Especially when you look at things like administrative burden, childhood or infant mortality. These are things that we can do better at. And unfortunately, although our ranking is dead last, our national health expenditure is at the very top of the mark. We spend today close to 20% of our gross domestic product in the United States, nearly $4 trillion on our healthcare costs. And that combination is clearly not ideal. We know that we can do better. On November 29th of 1999, the Institute of Medicine released a paper called "To Err is Human." On that paper, if any of you have read it, I suspect some of you have, there was a cover image of an airplane, and that represented the number of preventable deaths every day in hospitals. Today, in the year 2020, 1,000 people die every day from a preventable medical error. In fact, more than 1,000 people. That's the equivalent of 2 jumbo jets crashing every single day in the United States. Thinking about that, again, our opportunity is to ensure that when we look at being great at what we do, first and foremost, we have to think about that patient experience, that quality and patient safety component to ensure that our patients always get the very best care. In addition, when we look at the cost that we have across the country, there's an amazing amount of variation in terms of what we spend. So looking at these two maps, just knee replacement and hip replacement, the numbers here that you see are not the cost of a knee replacement or a hip replacement. They're actually, amazingly enough, the variation in the cost for a knee replacement or a hip replacement. So these big red circles mean that in those communities, there can be variation of nearly $20,000 from one site to another. Recognizing that today we live in a country where 40% of Americans have high deductible insurance plans, they are actually taking a much more active role in determining where they should get their health care. And to a large degree, they're shopping. They're trying to get a sense of what their out-of-pocket costs are going to be. So these costs are playing a bigger and bigger role in where patients are choosing to go to have their orthopedic care, which in most cases is elective care. This is perhaps one of the most interesting slides that we'll show today, and that is the fact that on the left, you see Medicare cost per person. You can see that it goes anywhere from about $6,500 per enrollee to about $18,000 per enrollee. And on the right, you see how the various states ranked in terms of the quality of their healthcare system. And it shouldn't be a surprise that the states that have the lowest rankings in terms of quality also have the highest costs. So there is a very clear direct relationship between improving quality and decreasing costs. And think about that. It certainly makes sense. If you do a hip replacement right the first time and that patient doesn't have a dislocation or doesn't have an infection, it is less likely that they will be readmitted to the hospital, have a secondary procedure, or come back to the emergency department. So all of these things really do fit hand in hand. This is clearly not an area where the more we spend, the better we get. In fact, we need to be more cognizant of what we spend our money on to ensure that our patients do get the very highest of value. We also recognize that we're working in an area with high industry pressures. There is a clear lack of stakeholder alignment. I've always been surprised when as a hospital CEO, for example, I would hear about the fact that we're in negotiations with one of the payers, and those negotiations might get a little sticky. The reality of it is we should be more aligned. The hospital providers, the payers, the physicians, all of us should really be aligned around ensuring that our patients get the very best care for the very lowest cost. We also recognize that margins are decreasing. As healthcare costs go up, as we get more and more advanced technologies and reimbursements go down out of necessity, we have to become more efficient. More and more companies are now becoming active in terms of publicly reported metrics and costs. These have actually introduced a whole new challenge to many healthcare providers to ensure that they can remain competitive in an era of high transparency in healthcare. And finally, this idea of more care being shifted to the outpatient space is a very scary thought for many hospital executives. Again, I can tell you firsthand, having been the CEO of a $2 billion healthcare system in South Florida, we were always nervous when we would hear about our high margin business like total joint replacements or elective orthopedic surgery moving to the ASC setting. But the reality of it is patients that do receive appropriate care in those settings usually have lower out-of-pocket costs and higher overall satisfaction with their care. So this is not something that we should, in fact, be resisting, but we ought to be ensuring that all of the stakeholders are appropriately aligned so that hospitals can do well with patients moving to an outpatient setting. And David's going to talk to you a little bit more about that in a few minutes. One other area that clearly requires some focus and some time is this idea of caregiver burnout. I think it's never been more clear to folks than it has been recently with the issues around coronavirus. We've seen caregivers really working extraordinarily long hours and working very, very hard and putting their lives on the line. Even before COVID, though, it shouldn't surprise you to know that 50% of caregivers have stated that at one point or another they have felt that they were burned out. This is a massive opportunity for us to really reintroduce the joy of medicine into the delivery of medicine. If we can get better at providing that high quality, low cost care, medicine really does become more enjoyable to deliver because you're not so focused on what's the bottom line. And I think that's a major opportunity for us to reintroduce the joy of healthcare to our caregivers. In terms of why we've chosen the musculoskeletal space to begin with, it's actually really quite obvious when you look at this map. Musculoskeletal care is now, depending on what you read, either the second or third highest expenditure in healthcare. It's certainly the second largest for Medicare, representing about 17% of the Medicare spend today. On the other hand, cardiac care, which had been the highest spend, has actually been going down over the last several decades. And I'll share why that is with you by looking at this graph. On the left, you can see heart attack discharges in the United States. Between 2000 and 2010, they went down by 53%. Between 2010 and 2020, they continue to go down. Why is that? Because we've gotten very good at managing coronary disease through medications. Drugs like Lipitor, like Crestor, like Prevacol have all changed the face of and the incidence of cardiac disease in the United States. On the other hand, as patients have gotten older and are demanding more of their bodies to stay active, orthopedic care has actually become more prevalent and represents a larger part of the healthcare expenditure. Between 2005 and 2030, we expected to see a 600% growth in the number of knee replacements done in the United States and 200% growth in the number of hip replacements done in the United States. And in fact, we are following these graphs quite well. Just this year alone, in a coronavirus year, we will still do more than 1 million total lower extremity total joint replacements in the United States, which will represent more than half of the joint replacements done around the world this year alone. I'm a big fan of Michael Porter's work at the Harvard Business School. Michael Porter talks about the definition of value as being quality over cost, and he really has encouraged healthcare systems and the healthcare community to really think about competing based on value. And he defines that as outcomes and patient experience. I might add to that patient access divided by direct costs and indirect costs. And we recognize that to really create a value-based healthcare network, we have to work together. We need some type of alignment vehicle that brings payers, hospitals, ASCs, physicians all together really around the patient to ensure that patients who are now bearing more and more of the out-of-pocket costs for healthcare, to bring them that highest value possible when it comes to their care. When you look at this spectrum, the United States still provides most of its care on the left side in a fee-for-service world. This is really a sick care model, meaning that you go to the doctor generates a bill, the doctor gets paid. You get admitted to the hospital, you go to the emergency department, a bill is generated, the hospital or the emergency department are paid, and hopefully you get better. But this is a model that very oddly enough thrives in a sick care world. Very different than the very right side of the model, which is a population health model, where patients are actually, hospitals, patients, and payers all benefit from patients being kept healthy and doing better. And you can see that there are several steps to getting there. Performance-based models, which normally include some potential upside based on shared savings, the bundled care, bundled payment models, which have been very popular with bpci and CJR. Frequently, though, these really do become a race to the bottom, and many of you that have participated in these recognize that after a year or two, most of the savings have really been eliminated, and as a provider, there's no significant savings left for you. And finally, this idea of stakeholder alignment, and this really is the opportunity. We have gone for decades, in fact, one might even argue centuries. As long as there have been payers that are separate from providers, there's always been a little bit of a lack of alignment in these areas. Our goal is really to be that vehicle to bring alignment amongst all of these players so that patients, providers, musculoskeletal vendors, facilities, and payers are all working together to really try to improve the quality of care and decrease that cost. The way we do that, I think, is very unique, and I'm going to turn things over to my friend and colleague, David Jacofsky, to take over from here.
Thanks, Will. So I think what you've heard really is well outlined by Will as the problems that we currently are facing, not only in musculoskeletal healthcare today, but really in healthcare in general. The way that we think about the solutions, the way that we believe everybody should think about the solutions, is really centered around stakeholder alignment and the concept of an integrated delivery platform. So whatever platform or solution you choose, it really, to be the most successful, needs to have a component that allows you to have a management services arm so that you can most effectively and efficiently manage the providers, not only potentially manage them in clinics if they're employed, but certainly manage them within health systems in terms of quality outcomes, and then ideally also be able to manage them in clinically integrated networks. You have to have an IT ecosystem. Right now, we have all these disparate tools in healthcare, whether they're patient-reported outcomes tools, whether they're the hospital EMR as compared to the clinic EMR, whether they're claims data that you may have access to. How do we get standardized definitions around all of these disparate systems and create one common data warehouse? People have talked about that as being the holy grail, but actually it's quite achievable if you invest and put your mind to it. You have to be able to manage the hospital service line. So the physicians, what they do outside the hospital is critically important, but it's very important that the hospital service line continue to transform as the market transforms. Without hospital service line transformation, it gets very, very difficult to put, number one, the right patient in the right site of care at the right time, and number two, to have the experience, the length of stay, the outcomes, and the post-discharge disposition be optimized during that care episode. You have to have facilities that are fully integrated. And what I mean by that is the stakeholder alignment and partnership between the providers, the health system, the payer, really should all be focusing on putting the right patient in the right care setting. And that means that might be a clinic care setting for epidural steroid injections. That might be, where do we put a healthy 27-year-old for a carpal tunnel release in an ASC, versus a specialty hospital, versus a community hospital, versus tertiary and quaternary care hospitals with extensive ICU facilities for the revision spine patient who might be on the transplant list, but actively needs to have that intervention. And so the ability to manage that entire facility continuum in an integrated and evidence-based way is critically important to transforming the market. And then you have to have a different level of medical economics understanding and acumen. You have to have a team that really understands medical economics, or you have to have a partnership with an organization that can think about claims and cost in some new and unique ways. And if you have that integrated delivery platform, you as an organization will be able to really drive and lead the market transformation from fee-for-service to full global population health models, and do it in a way where everybody wins. The health system will make more money and be more profitable. The providers will make more money and be more profitable. The payer will save money. And most importantly, the community and the patients in that market will have better outcomes, at a lower cost with improved access. Now, we fully recognize, having partnerships across over 100 locations in the country, that every market is unique. And when you think about your market, whether you're a health system, whether you're a payer, or whether you're a provider, you're probably thinking, my market's different. My market is very different than everybody else's. And we know all markets are different. How much Medicare versus commercial, how much Medicare versus Medicare Advantage might be in your market. What's the dynamic of the employed physician in musculoskeletal health in your market versus the community physicians? And if there are community physicians, is it one giant practice that controls the market or 15 small practices? How far along the transition from fee-for-service to value-based care is your market? We work in some markets that have been doing bundles for a decade and are very advanced on the value-based care culture side. We have some that are sort of very early in their development of value-based care cultures. And is it an integrated health system in that market? Is it a fragmented health system? Does the hospital system own the plan, or are they very separate? So every market is different, and it's important to understand that each market will have a customized strategy and solution for how to get across this bridge to integration and value-based care. But I think the principles we're going to talk about here over the next few minutes, the way that we think about the fundamentals for solving the problems that Dr. Barsoum outlined at the beginning of the presentation, are fundamentally and largely the same. You need to invest in real-time, accurate data that you not only have confidence in, that not only is actionable, but that the providers have confidence in. Without being disparaging to the world of data today, using claims-based data that's 6 to 12 months in arrears and has a 30 to 50% error rate based on many of the publications that we've put out over the last few years, probably not the best way to drive behavioral change in the marketplace. So you need to invest in a meaningful way in the ability to deliver real provider scorecards. Those provider scorecards need to be based on quality performance in the hospital. They need to be based on population health or bundled payment performance, but they need to be presented and delivered in a way that is believable to the providers and allows the providers to engage with those reports, knowing that they're accurate and timely. You want to have reports around clinic operations, especially if you are managing physician practices. Employed physicians tend to, hospital employed physicians tend to have a very poor visibility into clinic operations, and oftentimes those operations are not as efficient as they should be. But being able to provide efficient operations to improve the patient experience will also lower cost and improve value. You need dashboards around quality and clinical outcomes. We have spent a lot of time investing in predictive analytics and AI. Those are both buzzwords that generally mean very little when you drill down into them. But I think what you're starting to see now is the development of real predictive analytics. We've focused a lot on the concept of wearable sensors for passive data collection, the ability to predict preoperatively what the post-discharge disposition of a patient will be so that you can proactively plan for those episodes. What's the appropriate site of service for a certain patient with certain comorbidities and a certain procedure? And then how do we develop real-time, anytime dashboards so that leadership can look and drill down into individual providers in the marketplace in real time, individual clinics, individual hospitals, individual MA plans if they're taking risk on those plans, or individual bundles, in ways that allow you to have actionable data today. So you're not waiting 4, 5, 6 weeks after the end of a month to get data that's now 4 or 6 weeks old. Perhaps equally or more important is the concept of medical economics visibility. I don't think that any of the payers would argue with the fact that their claims analytics software systems are primarily developed and built to adjudicate and pay claims. The way that the attribution models work with many payers can lead to mischaracterization of costs. For example, many payers will look at an individual physician provider, and based upon what percentage of the time surgery is performed for a new diagnosis of knee arthritis with that provider, that might drive the appearance of increasing costs for that provider as compared to a different provider. But what many payers, for example, don't do is look at what's the cost for the practice, because if you have a suite or a large number of mid-level providers who are screening the patients and managing the non-operative care for less money than those providers would normally be getting in a fee-for-service model, such that any patients seen with a new diagnosis of knee arthritis to that physician are likely, ideally, to need a more expensive intervention. That provider actually might be providing more cost-effective care, but in many of these attribution models will look like they're the most expensive in the market. There are a whole host of things we can talk about related to even looking at bundled comparisons where physicians who see more hip fractures because they're on call more often might have a higher bundled cost for total hip replacement, which might be done for a fracture instead of an elective arthritis case. All of those things need to be normalized in the data. So we invested a lot of time in both a team and in a system so that we can ingest claims from payers. We can then trend those claims for our 26,000 or so ICD-10 codes around musculoskeletal care. We can bounce each of those line items off of our benchmark, and then we can set up savings initiatives and targets for the following year. So for example, we may look at a population that we take risk on and say, for this population of 100,000 members with an average age of X and an average RAF score of Y, we believe that 68% of shoulder arthroscopies done for rotator cuff tears should be done in an ASC. But what we're seeing in this data pool is it's 38%. So there's a 30% delta between what our target should be in a well-managed practice and where we are. We can look at that, we can set targets, and we will know by individual provider who and how we need to motivate in order to drive the cost savings, but more importantly, the best site of care for that patient. We do the same thing with readmission rates by diagnosis or return to the emergency department, length of stay at SNFs compared to benchmarks for different diagnoses. So now you have actionable data, you have real benchmarks that have been clinically proven, and then you can develop a plan around that. That plan can then be tracked so you can look at what's happening to our quality outcomes over time. And then we generate from that individual facility, whether they're SNFs or hospitals, and individual provider scorecards related to bundles or population health so that the financial incentives of the individual providers are aligned with those of the payer and the health system. Again, so everybody shares in the success of market transformation toward value-based care through these alignment strategies. To give you an example, the Core Institute was a physician practice that we partnered with in Phoenix in 2008. In partnership with them and with one of the health systems in the Arizona market, we developed this market transformation strategy. We were able to build a network of over 200 musculoskeletal providers around that particular health system. We're able to double the contribution margin for musculoskeletal care over a 2.5-year period at that health system. And we were able to move significant market share to the health system and the hospitals that we partnered with. Subsequently, in partnership with stakeholders, we developed a $100 million specialty hospital that became a center of excellence for spine and arthroplasty and has the lowest complication rate in Arizona if you look at the Medicare data. Within those hospitals that we partner with, we were able to optimize their service line to, again, improve efficiency, improve profitability, improve contribution margin. Ultimately, all of that led to the development of the first statewide clinically integrated network to manage population-based risk for the MSK spend in a state in the country. And so now that has been launched. One of the things that's important to remember is patients like value. And what I mean by that, getting back to Wael Barsoum's point earlier, the highest quality care is the most cost-effective care. And so the perception by many, inaccurately, is that these highly efficient clinics and these highly efficient health systems, many times people will say, oh, well, it's like herding cattle, for example. The reality is when you look at the Ranking Arizona surveys, which are consumer surveys done each year, so these are patients that are filling out these surveys, this was voted the #1 delivery platform for orthopedics, the #1 quote orthopedic practice, if you will, although it really isn't the traditional practice, for the last 9 years. And so not only do these programs improve efficiency, not only do they save money for payers, not only do they improve profitability for all stakeholders, not only do they help align musculoskeletal vendors, but they also are preferred by patients for the patient experience and for the value that they provide. And within the hospital, the alignment of stakeholders allows for a much more robust strategic planning process. We can focus on how do all of the stakeholders work together to strategically plan over time this transition, so that you don't have competitive groups, orthopedic surgeons who own an ASC suddenly ripping all of the volume out of the hospital because their primary focus is how do we make an ASC more profitable, but rather you focus on how do we transition the market, how do we make the hospital more efficient for when the physicians are in the hospital, how do we create multi-partner joint ventures on the outpatient side so that as cases are shifted out, everybody is winning together, and how do we do that in a way that is planned, strategic, and allows everybody to focus on what makes sense for all stakeholders. I'm not going to go through all the data on this slide, but in summary, you can see quality improves, operational aspects of the hospital and the facilities improve, financial performance will improve, and you can see significant shifts in market share to those participating groups and those participating facilities, all while increasing the draw beyond the primary and secondary service areas of what traditionally would be seen by these health systems and groups. So the concept that you can improve quality while becoming more efficient and making more money and moving market share, that you can't do all those simultaneously, is clearly erroneous and has not been our experience. If you were to compare, as we have here, physicians in a market that are in a program, a HOPCo managed program in this example, but really this holds true for any of these robust programs, versus other providers in that same market and that same health system that have chosen not to participate in these quality-based and stakeholder alignment programs. You can see dramatic differences. Not only this happens to be for lower extremity joint replacement, but I promise you we could show you other slides for other procedures that look the same. Not only for things like bundled payment costs, percent of patients that go to skilled care post-operatively, et cetera, and not only in things like anchor length of stay for the same procedure, but things that really matter both to patients and their families, and also obviously to the providers that care for them, things like mortality rate, where there's almost a 50% reduction in mortality rate over time for those participating in these programs and not participating in these programs. And so every market will transition to value-based care. There's new talk now from CMMI and CMS about potentially going back to mandatory bundles. We'll talk a little bit more about bundles in a minute. The speed in each market will vary. Again, some markets have already been doing bundles for quite some time. Some of them are very nascent in those markets. But whether you look at bundled payment programs or pro-fee capitation or population health joint ventures with stakeholders, ultimately, I think it's very important that you think about what your plan is in your market. I can tell you doing nothing is deciding to do something is probably not the best decision strategically. And I think regardless of what path you follow, figuring out what the something you think makes sense to do next is probably a worthwhile exercise. So when we think about population health, it's a bit of a paradigm shift for physicians and for facilities, because instead of taking care of patients when they're sick, our goal is to figure out how do we help keep the community healthy. And so we have prevention and wellness programs that are pushed out from the facilities, from the physicians, from the network in partnership with the payers, and in many cases with musculoskeletal vendors in some cases. And so this program provides a needed service to the community. Now, given the growth in orthopedics, certainly there's no shortage of volume, and we've seen massive market share shifts, as I mentioned, when these programs are initiated. So certainly there will be evidence-based protocols around what is an appropriate intervention, when and who do you require certain surgeries, and you want to make sure that that utilization is appropriate. who needs an MRI of their spine? Should somebody with 2 days of back pain get one? And if so, what are the red flags that would indicate they should, as compared to getting one for every individual with back pain for 2 days? When you do initiate an episode, how do we make that episode efficient? How do we make it cost effective? How do we decrease implant costs? How do we decrease length of stay? How do we decrease readmission rates and complications? And then ultimately, on top of that, to transition to full value-based care and global risk, you have to figure out what your risk infrastructure looks like. How are you going to price your at-risk contracts? How are you going to create the benchmarks for those for that pricing? And then how are you going to drive predictable performance in those programs in a way that all of the aligned stakeholders can win together? Because bundled payments are interesting, but one of the things to think about when we talk about bundled payments is it's very different than true value-based care. Certainly is in the bucket of value-based care and is the thing that people talk about the most. That being said, though, it still has a trigger event. It is still a fee-for-service contracting modality. And because it's a fee-for-service contracting modality, it doesn't necessarily impact overutilization. It doesn't necessarily encourage orthopedic surgeons, for example, to optimize patients to help them eliminate a surgical procedure. The other problem is that the savings potential is limited. If we're trying to truly create significant savings in healthcare, we need to look at a certain diagnosis. And in this example, we're going to use knee arthritis. In the example of knee arthritis, only 25% of the total cost of care is related to surgery. So if we were to save 10% in a surgical bundle, that 10% would only equate to 2.5% of the spend for that diagnosis. And if you look at back pain, for example, spine surgery only makes up 9%. So to improve bundles in spine surgery and have an impact of more than 1% on the total spend for back pain is problematic. So we leave a lot of money on the table. And so sometimes people talk about shared savings as being the solution. And although shared savings has some advantages over bundled payments, there are still a host of problems. Because if we were to look at the spend for last year, and we were to say we can drive savings down to the dotted line here, and then we were to partner with physicians and payers and health systems to drive the cost savings, and then we were to split the cost savings among the providers, the delivery side, the practice and the health system, and the payer, generally you're going to now set a new benchmark. And that new benchmark is going to decrease the opportunity. And again, the health system and the practice that deliver the care will have a reduced opportunity, and the payer will have an increased opportunity. But even if you're the payer, this is a bad idea, because what we have seen in markets with both bundles and shared savings programs is care redesign is pushed by the providers and the physicians until their opportunity is gone, and then they don't care anymore. Then they stop trying. They don't put the effort, the investment, and the work in. These are not sustainable models. And so we really feel like everybody should be focused on models that are truly sustainable. And the way to do that, the way that we believe you should do that, the way that we do that, is we effectively become, in partnership with all the stakeholders in the markets that we're in, a subcapitated insurance company, if you will, not from a legal and licensure perspective, but effectively through a risk pool. We are subcontracting all of the risk for 26,000 ICD-10 codes. So about a third of all the ICD-10 codes, about 20% or so of the Medicare spend in most markets, we will take global pro-fee risk, everything but outpatient pharmacy for those codes. And as premiums go up, revenue goes up in that risk pool, because it's generally a percent of the premium, and it's based on mining 3 years of claims and agreeing on what that percent of premium should be. So this is a highly sustainable model, because we know that orthopedic trends are increasing. So you have to have a trend that increases, although our goal is for that trend to increase more slowly than traditionally we have seen. But this is a fully sustainable model. The payer shares in the savings, the members subsequently share in the savings through lower premiums, and the health system and physicians do. So here's an example that I think really points out how well this works. This was a group of 114,000 Medicare Advantage lives in the Phoenix market. And through this network, which was a joint venture that we created with the providers in just this Phoenix market and a health system in the Phoenix market, we were able to take what was a 15% year-over-year increase in cost on these 26,000 lives. We agreed with the payer on what the pricing should be. We signed a contract to begin this in January of 2017. We signed the contract, as you see here, in September, and we started to educate the health system and the providers on how we were going to get paid in this program. We launched the program in January of 2017, and you can see that over a 2-year period, we went from what was a historic 15% year-over-year increase in spend for that same population to a negative 6% trend, which is unheard of for Medicare-age musculoskeletal care, which equated to a $32 million annual run rate savings just on those 114,000 lives. So you can see how this is a significant, has a significant impact not only on the market, but on the opportunity to drive down premiums and meaningfully bend the cost curve. And we did this in this market with disparate providers, meaning in this network, 35% of the providers that were providing this care were HOPCo managed surgeons, meaning they were in a physician practice like the Core Institute that HOPCo works with on physician practice management. 16% were hospital employed physicians, and then about half were in about 15 private practice groups that traditionally were competing with each other, and now we're aligned. And part of how we do this is we have a process by which we provide templates and we provide a team of folks that allow physicians to participate in the creation of standard order sets, clinical pathways, protocols, and patient education materials. And it's critically important to understand that this is largely about the process. How do you have this process led by orthopedic surgeons in a turnkey way so that all of the physicians feel like they were part of the process, even if you already know the outcome when you start the process. Critically important to remember, though, is that we focus on diagnosis-based templates and order sets, not just procedures. So it's not about just how do we standardize around a knee replacement in the hospital, but it's rather how do we standardize the market, the community, around the management of knee arthritis. And then with the claims data in this population, again, we will look at each of these different benchmarks. This is just one of many operational planning scorecards. We'll look at the per member per month current cost in that population, bounce it off our benchmark, and then we'll decide how much do we think we can save in this market over the first 12 months for each of these line items, ultimately delivering to each provider a scorecard, reviewing the scorecard with them so they understand where they are and what opportunities are still left on the table and how much money they're leaving on the table, both for them and for the joint venture of all the stakeholders through the ways that they are or are not performing. And so in summary, I think, step one is how do we align? How do we align musculoskeletal providers, facilities, payers, vendors, and patients in a win-win joint venture structure? I think that's a question that's important to ask yourselves as you move forward. If you can align the stakeholders in your market, then you will be able to manage the musculoskeletal service line much more effectively and more easily at the facilities in that market. And then if you are able to manage all of that more effectively, you will create the integrated high-value go-to network, go-to facilities, not only for patients, but also for payers to know are the best places for their members to get high-value care. And if you do all of these things, you will win. You will win improved outcomes for your treasured patients. You'll win improved market share, improved financial performance, improved stakeholder alignment and engagement in your marketplace, and increased value for the communities in which we all serve. So with that, we will, I don't know what just happened there, sorry. With that, I think we have some time for questions.
Great, thank you so much for that phenomenal insight today. We'll now launch into our audience Q&A. Audience, if you have questions, please continue to send them in. Let's see what questions we have already. Our first question is for Dr. Jacofsky. What year did you start the population health program? How many years go into the 60 million?
I'm sorry, what was the second part? How many years go into?
How many years go into the 60 million?
Oh, so in the example that we, the population health program in the specific example of the 114,000 lives that I showed was started in 2017, and it was about 2.5 years that would generate that 60 million in savings for that particular plan. That's one of many plans. That was just a sort of a case example. Different markets will move to population health at different speeds depending on where they are. We've been doing value-based care in one form or another since 2007. In 2007, we created quality-based scorecards that we would adjust our fee-for-service each year based on the prior year's performance on the quality scorecard. And we were part of the original bcpi pilot program. So we've been doing bundles in one form or another in different markets since 2009-ish.
And Dave, just to add to that $60 million over the course of a couple years, that's actually after physicians have been paid their bonuses, after administrative costs. So that's actually what is left over to the owners of the clinically integrated network, which in this case included the hospitals, HOPCo, as well as many physicians.
Great. Thank you. This question is for Dr. Barsoum. How does this model work with a large academic institution?
Yeah, that's a great question. So presently, we actually manage service lines at several large academic institutions around the country. As a general rule, I mean, both David and I are fairly academic orthopedic surgeons. I think between the two of us, we have probably around 400 peer-reviewed publications. So we're very active in this. We have a real appreciation for the work that's done at academic medical centers. Look, every orthopedic surgeon, whether they're in an academic institution or in private practice, all want the same thing. They want a highly effective, highly reproducible, highly efficient place to do their surgeries. They want efficient clinics to see all of the appropriate patients at the right time, and they want the right places to do their procedures. So the truth of the matter is, whether it's an academic medical center or a private hospital with private ASCs and private practices, the alignment is all the same because the desires on the part of the physicians tends to be the same. And candidly, the expectations on the part of the patients are the same. A patient doesn't care whether your salary as a doctor is paid for by a university or comes through your private practice. They care about the quality of the care that they receive and the value that they're getting for their out-of-pocket cost. So from my perspective, the model works just fine in the academic institutions that we serve, as well as the private institutions.
Great. Dr. Jacofsky, how does this model with fee-for-service, how does this model work with fee-for-service based systems?
Yeah, that's a really good question, and it's also a very important question. The way that our population health programs are set up are to make them very easy. So people talk about, quote, clinically integrated networks all the time, but the definition of a clinically integrated network outside of sort of a standard legal definition is highly variable. And what we try and do is take the existing network of a payer and we will overlay our program right on top of it. So the payer will continue to adjudicate their fee-for-service claims the exact same way they always had, and we will effectively be charged the cost of all those fee-for-service payments. We lay on top of that program all of our care redesign and all of the data analytics, all of the process improvement, all of the outreach, the nurse navigation, et cetera, so that we're able to drive a cost savings by entering into that existing network and working with those physicians, whether they're orthopedic surgeons, whether they're ER doctors, or whether they're PCPs that take care of, for example, musculoskeletal issues, as most of them or all of them do. So it actually, that was a long way of saying it really has no impact on fee-for-service, but it is the best way for health systems and physicians to improve their reimbursement on top of their fee-for-service through the payment of both bonuses for population health or bundle payment performance, or through quality bonuses in the hospital in ways that really can transform the relationship between the payer, who's seeing a significant bending of the cost curve, the health system, and the provider group.
Well, thank you. This is for Dr. Barsoum. How would you address health policy to incentivize transitioning to value-based versus fee-for-service?
So that's a great question. So first and foremost, you have to walk the walk, right? You need to have a real track record in bending the cost curve and being able to prove that your methodology works. So the fact that over the last several years, HOPCo has that track record makes it very easy for us when we speak with government leaders around the country around helping redesign some alternative payment models and that type of thing. So that's number one. The second thing I would say is education. I mean, we're very involved in terms of putting on our own courses for bringing value, introducing value into healthcare. Those are usually very, very well attended. And those courses, I think, do educate more people around this kind of work. And then finally, direct relationships that we do have with government leaders at the federal level and the state level. Many times I'll get phone calls, David gets phone calls around various opportunities around alternative payment models, and we'll weigh in on what we think is the right model. I mean, you know, I think one thing to recognize, and they've clearly recognized this in government, is that healthcare is very complex, and what we're proposing here and what we've delivered on here is not easy. I mean, it requires a lot of moving parts to be well aligned. That is exciting. But if you've never done it before, it can seem a little daunting. And I think our government leaders have recognized that and recognize that there's only so much they can stress the healthcare system with new changes. But this clearly is a natural next step in changing the way we deliver healthcare. If we genuinely believe that we spend too much on healthcare, which I think most Americans would say we do, if we genuinely believe that we ought to be able to get more for our healthcare dollar, which most Americans think we should, then that is a message that rings very true with politicians, regardless of what their desired alliance is, whether they're Republicans, Democrats, or independents. And in fact, we have relationships with folks on both sides of the aisle that clearly see the value in what we're doing.
Great. We have time for one final question, and I'll propose this to both of you, because I know you'll both have an opinion on this. What beyond what you've described here today do you need to succeed with more medically complex patient populations?
Yeah, I mean, I think the more complex the patient population is, the initial knee-jerk reaction is to say the harder it is to take risk. The reality is that's not always true. Oftentimes, the most complex care has historically been the most disjointed, fragmented, and ill-managed, so to speak. And so many times when we look at data on the most complex end of the care spectrum, there's actually the most savings and care improvement opportunity. So I wouldn't necessarily sort of just automatically assume that the more complex care is harder to take global risk on. We effectively take risk on all of the diagnostic codes around musculoskeletal care. Where you do sometimes see some issues based on complexity related to our model is in a few small sort of corner cases, musculoskeletal oncology, or really complex musculoskeletal pediatric tumors, for example, or pediatric infections of bone and soft tissue. Because in those cases, you may have 4 or 5 different types of doctors. It's very multidisciplinary, and that sometimes can make it even more challenging to align all of the stakeholders. Not impossible, but now you've got to get radiation oncologists, medical oncologists, orthopedic oncologists, infection doctors, pediatricians, et cetera, all to be aligned around how they're providing this sort of care. So I don't know if that was the gist of the question or if I missed it, but I would say we generally take risk on somewhere between 97.5% and 99% of all the codes. The few things that we do carve out are things like pediatric orthopedic oncology many times, because it is a little bit more challenging to be able to manage that. Will, I don't know if you had other thoughts on a different angle from that, but.
Yeah, I think the only thing I would add is, the complexity of the patient isn't really an issue with this model. And the reason is, when you look at the various populations, the way we build out costing of the model is based on the historical trends in that community. Payers are actually great partners to us. We work very, very well with all of the major payers. So by having access to their claims data before we actually launch, that allows us to price the model out correctly. Once that pricing is done, we continue to get claims data afterwards to ensure that the care is correct. So again, from the payer perspective as well as from the provider's perspective, it's a win-win, because those higher risk, more medically complex patients actually there's more of a drive to optimize them before their procedures, or to ensure that they're getting the appropriate care from the very first time, as opposed to cutting corners. So regardless of the medical complexity, the model still works because of the partnership that we have on the payer side.
And the complex patients, by the way, are one of the biggest opportunities to help drive down the cost of care inside the hospital. Many of those patients are historically high-cost patients with excessive length of stay compared to other similar category of diagnoses, and coordination of care through these models can dramatically improve hospital financial performance on what otherwise might not be very profitable patients on the facility side either.
Great. Thank you so much. That takes us to the end of our hour, and it's time to conclude the presentation. Thank you again to our presenters, David and Will, for sharing your expertise with us today. Thank you to our audience for such great questions. To our audience, we value your time and appreciate your feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you in the future. We'd like to once again thank the sponsor of today's webinar, Healthcare Outcomes Performance Company, or HOPCo. To learn more, visit their website at hopco.com. This webinar will be available on demand, and a link to a recording and a copy of the slides will be sent to webinar attendees within the next 48 hours. This concludes today's presentation. Thank you again for joining us today, and have a great rest of your day. Thank you.
Thank you.
Thank you.